the record. Okay, let me start again. We have a very dynamic and versatile personality of 25 years of experience as a clinician, academician, and researcher in the field of optometry. She is a graduate of Elite School of Optometry. She started her bachelor's and then upgraded to MPhil at Pilani and done her master's in business administration. Wow. And also got a PhD in optometry. She worked at Shankaran Netralia for 9 years, 11 years at Sri Ramachandra University in research at College of Health Sciences, and also at University of Buraimi, Oman. She also was an assistant professor at Abaya College of Health Sciences. Of course, all of you have received the long CV. I made it a bit short. And experienced person as a vice principal and global head optometry education at Dr. Agarwal's Eye Hospital and group of institutions. She was also professor and head of department of Chandigarh University just before she joined as the principal of Chaitanya Foundation, Chaitanya Institute of Vision Sciences. Her areas of research are binocular vision, pediatric optometry, contact lens, and orthoptics. She has got various awards. To list a few, she got the Young Investigators Award in 2009, followed by Australian Awards Fellowship at Brian Holden Institute, University of New South Wales, Sydney, Australia, international and national presentations on binocular vision, contact lens fitting, keratoconus, special fitting, conventional methods of amblyopia treatment, experiences in Fresnel's prisms, name any topic in binocular vision. I see her having presented, and there are various publications, some of them related to dry eyes, accommodative facility in tennis players versus more sober workers. And what is so special about her is that she's very optimistic, vibrant personality, and always has a positive attitude. And I do not know whether she took on some course on MBA. Her subject specialty was on stress management and self-management, which she's very good at from my experiences with her. We have her here to share the clinical pearls in the management of anomalies of accommodation and convergence. Dr. Srinivasan. Jai Rajini Srinivasan.
Thank you, Tanuja. Thank you for the fantastic introduction. So anyway, I'm tempted to get this golden opportunity to share a little knowledge, whatever I have in the field of binocular vision. So this is, of course, the most favorite field in the broad spectrum of vision sciences, optometry. When I say binocular vision, it's just not optometry, it's a vision science. So the ophthalmologists depend a lot of, for the management per se, to benefit the patients, they depend on us. So I'm not going to pitch into the strabismic part. I'm going to pitch into the non-strabismic component. So that's why myself and Tanuja, we chose this topic so that it's going to be very relevant for the optometrists, because this forum is basically focusing on the optometrists. So let's see the role of an optometrist in management of anomalies of accommodation and convergence. Am I audible? Is my voice okay?
Yes, ma'am.
Beautiful.
Yeah, thank you. So one condition before starting, I think let's make it very interactive so that, I'm going to share a very, very basic thing so that it's going to be a start. And of course, we will take it to a bigger way. And I seriously appreciate Dr. Tanuja, Mrs. Tanuja, for such a wonderful initiative. She started from Botswana and it's spreading like a it's a forest fire kind of a thing, the entire huge African continent. So anyway, so I'm going to proceed with my talk now. So when I say accommodation and convergence, we know that accommodation and convergence are synkinetic. So usually it's a little tricky to, manage which comes first and which comes. It's like the chick and the egg kind of a concept. So the simple thing is accommodation, it can be uniocular, and also binocular. When I say convergence, it is vergence. It is definitely binocular. So that's why people put it in a very nice way, accommodation and eye movement disorders. So moving on to binocular vision disorders. As I told, I'm going to stick on to the non-strabismic components. So therefore, it is vergence and accommodation. So when I say vergence, it is just not only the conjugate movement. The conjugate movement means both the eyes moving in the same direction is called conjugate, and both the eyes moving in the opposite direction is called disjugate. So when I say disjugate, it is vergence, convergence. It moves towards both the eyes. Is it? What is it? It is conjugate or disjugate? I'm going to leave it to you people so that we don't have any kind of, at least when we finish this talk, even in the prayer, it's like, let's complete the webinar in a very nice way so that the take-home message, we have learned something from here. So when I say conjugate, what does it mean? And disjugate, what does it mean? Tanuja, I can make it interactive, isn't it?
Certainly.
Yes. So conjugate means, anyway, no problem. I know the crowd will come. You can join me. It is a same direction. When I say same direction, if it is towards the left, it is towards the left. So therefore, the conjugate would be vergence, and the vergence are disjugate movement. One eye moving to the right side and the other eye moving to the left side. Therefore, it brings in towards the nasal, it's convergence, and away from the nasal, if it is like this, it is divergence. Therefore, the disjugate movement is vergence, and accommodation is basically the focusing ability of the eye is accommodation. So let's move on to what kind of disorders we get to see in vergence and accommodation. So when we get into vergence disorders, as I told you, two components, convergence and divergence. Under convergence, very simple, convergence insufficiency, convergence excess. Under divergence, again, it is divergence insufficiency and divergence excess. And there's another component called as pseudo-convergence insufficiency. Usually those days, I remember way back from my experience, when we started to establish orthoptics in, probably I can name the institution where we belong to, both of us belong to, Shankar Netralaya. We used to just do a very gross way of checkup of just, a pencil push-up test is done. You find out near point of convergence. You just say that, okay, this is NPC is receded, therefore it is convergence insufficiency. There wouldn't be a complete component of identifying if it is really convergence insufficiency or if it is divergence excess. So it's going to be, now that categorically we have a lot of, research has been done and a lot of clinical job is done from our side also. So let's see each component, what is convergence insufficiency and what is convergence excess, divergence insufficiency, divergence. What is the difference between the convergence insufficiency, divergence excess, and divergence insufficiency? Because they actually mimic the same, but ideally they are completely a different component, and the treatment modality also would differ based on our diagnosis. So therefore, then it is easy for us to identify what is that pseudo component. Pseudo is false, which mimics just like convergence insufficiency, but it is not true convergence insufficiency. So let's see what is convergence insufficiency. So first, I will just finish off the accommodative. Let me see if it is, yes. Okay. Accordingly, accommodative disorders. So I'm just outlining under accommodative disorders, we will have accommodative insufficiency, accommodative infacility, spasm of accommodation, also called as accommodative excess or pseudomyopia. So this comes under accommodation. Vergence we have completed. We have seen what are all the components, what kind of disorders you will have under vergence, and what are all the types of disorders you will have under accommodation. So moving on to the vergence disorders. Yes, convergence insufficiency. I'm sure you will be able to see the picture on the right top side. The convergence insufficiency people, I'm sure most of us here would have either a vergence disorder or an accommodative disorder. So usually it's like kind of they'll find very difficult. They'll land up in having a double vision. You know, the symptoms would be terrible, even asthenopia. So all these things are from the patient per se. But we have to look as an optometrist, any patient walking inside a binocular vision clinic or an orthoptic clinic would most likely they will come up with the symptoms of headache or asthenopia. So we got to find out what exactly is the culprit behind it. Accordingly, we have to design a protocol for a management. So under convergence insufficiency, of course, I'm sure you all know we do a cover test, cover and uncover test, alternate cover test. That is to find out if there is a presence of any deviation. As I told you, strabismic component, I'm not getting into the manifest component. The hidden component would be phoria. The manifest component is tropia. I'm not going to touch the tropia. It is only the phoria. So when I say convergence insufficiency, it is only phoria. So therefore, while doing a alternate cover test, you will identify the person has exophoria. And then we have to quantify how much is the exophoria. How it is found out by using a Maddox rod for distance. And nowadays we can also, even Maddox wing we can use for near, but to specifically say how much is the deviation, how much prism diopters is the deviation, it is better to do a Maddox rod test. So when we find out, you know, the phoria is found out for distance and near, if the exophoria for near is greater than the exophoria for distance, then you just keep it aside. So we have found that it is convergence insufficiency, but we got to confirm it by identifying accommodative convergence by accommodation component, that is ACA ratio. So when I told you the beginning of the talk, convergence and accommodation are synkinetic. So when one is weak, the other also will be weak. I'm sure all of you know the types of convergence. We have tonic convergence, fusional convergence. May I request the people to put in mute so that there is no disturbances. I think we are getting some disturbances in between.
Yeah, muted them. Professor Jaya, somebody texts me that they want you to go through the previous slides and they want you to slow down.
Once more?
Slow down, yeah. Because they want to digest the information.
I'm stuck here. 1 second. Yes. Should I start from here again?
Probably the next one.
So, yeah, message.
Yes, Gloria, am I okay? So, convergence disorders, convergence insufficiency, convergence excess, divergence insufficiency, divergence excess, pseudo convergence insufficiency. So, how are we going to identify convergence insufficiency, convergence excess, divergence insufficiency, divergence excess, and pseudo convergence insufficiency? These are the 5 disorders which comes under convergence. So moving on to accommodation, we will get accommodative insufficiency, accommodative infacility, spasm of accommodation, which is also called as pseudo myopia or accommodative excess. So let's see how to define convergence insufficiency. So moving on to convergence insufficiency, usually what we will do, we will just do a pencil push-up test to find out if near point of convergence is receded or if it is normal. that alone will not help us to find out if it is convergence insufficiency or the various other types of convergence disorders. Therefore, we got to also find out by doing cover and uncovered test and alternate cover test. As I told you before, I'm not going to touch the strabismic component. I'm just going to talk a non-strabismic. So when I say non-strabismic, latent component can be included into it, which is phoria. Am I okay? Is this speed okay, Tanuja? Is my speed of speech okay?
Yes.
Thank you. Thank you. So,
Yeah, it's okay.
yes. So when we take convergence separately as an entity, there are various types of convergence. Fusional convergence, accommodative convergence, tonic convergence, proximal convergence, and voluntary convergence. When I say proximal, proximal means awareness of the target when you bring it closer. So that is what we are examining when we are doing a pencil push-up test. So when you're doing a pencil push-up test, we ask objectively, you just see when the eye is moving out, when it breaks the fusion, that is the end point of near point of convergence. But when we are expecting the response from the subject, you got to ask them when the target is blurring and then when the target is doubling. So the end point of blur, break, and then you take the pen back until the target becomes single. That is called recovery. So the awareness of the target when it is blurring, that would be the end point of proximal convergence. And the blur is a component for, it's a stimulus for accommodation. Therefore, accommodative convergence would start playing inside, and also fusional component will start playing inside. So the break would be the end point of accommodative convergence and fusional convergence. This why I'm explaining you in a gross way, in a very quick way, in a clinic. Even we used to do some 20 years ago, 25 years ago, when we were doing our internship or post that, the development was not so much. So we used to just do a near point of convergence test and say that convergence insufficiency. If the NPC is receded, we call it as convergence, but that is not the right way of defining convergence insufficiency. Therefore, how do we do it? After doing an alternate cover test, we identify the subject has an exophoria. It is only a qualitative way of saying exo, which means the just uncovered eye will move inside. That is called exophoria, which is a latent component. But we got to identify, quantify the amount of deviation. How do we quantify? A Maddox-Rod test is done. So if I'm going to explain you step by step, I'm sure I assume that in a clinical practice, all of us are doing Maddox-Rod test. So under Maddox-Rod, while you're doing Maddox-Rod test, when you find out exophoria, base in prism is added until the patient or until the subject says single. So that's how you identify the deviation component. So we will know the value of both exophoria for distance and as well as for near. So when you compare these two values and you identify exophoria for near, if it is more, for example, if it is 10 prisms for near and 5 prisms for distance, which means you have identified the subject comes under the category of convergence insufficiency. The next parameter to say confirmed, you tell them that it's a confirmatory test. So what we do is calculate ACA ratio. As I told you before, accommodation and convergence are synkinetic. They are friends. So when accommodation is reduced, thereby convergence will be reduced. When convergence is reduced, even accommodation. The triad would be meiosis, accommodation, and convergence. But synkinesis is accommodation and convergence. So therefore, when you calculate using a heterophoria method, there is a formula for it, and you find out if the ACA ratio, usually the normal ACA ratio is between 4:1 to 6:1. If it is less than 4:1, if you find out if the value of that particular subject is 2:1, then it confirms convergence insufficiency. Am I okay? Any doubts? Any doubts? All right. So after identifying convergence insufficiency, how do we manage? So management protocol would be, first, ideally, we have to examine if the patient has a refractive error. Optimal spectacle correction is given. When I say optimal, which means usually the end point of subjective refraction would be maximum plus with the maximum visual acuity, minimum minus with the maximum visual acuity. Therefore, how do we confirm if it is optimal? The duochrome has to be balanced, which is, in duochrome balance means both red and the green, the letters in the red and the green band, they should be able to say that they're equally clear or equally bad. That would be the end point to say optimal correction I have given. The next modality of treatment would be plus lenses, because plus lenses, when you say plus, you put two basin would become a plus. So the plus lenses gives a basin effect, which is a relieving prism. Now, when I say relieving prism, there's one more component called exercising prism. So the difference between relieving prism and the exercising prism would be, relieving is that image will be shifted in a way that the double vision is eliminated and the subject sees single. When you say exercising prism, what we are trying to do is we are trying to bring in, when the eye is out, we are trying to bring the eye inside. So which means you're drastically pulling inside and cosmetically the eye becomes straight. Luckily, this is not a manifest squint. This is only a hidden squint. Therefore, for convergence insufficiency, the relieving prisms would be base in prism, and the exercising prisms would be base out prisms. If I'm going to talk about prisms, Tanuja will have to give me another 1 hour or 2 hours. So therefore, I think I'm going to proceed to the next slide. The prisms, when you say, I will just tell you this simple thing. The image will be formed towards the apex. So therefore, when it is exo, you have to put a base in so that the image will fall outside. Therefore, you're not shifting the eyes, you're only shifting the image. That is why relieving prisms, it is base in prism. And exercising prism, we put a base out. Therefore, the eye, if it is exo, you're trying to pull the eye inside. That is why it is called exercising prism, and you give a base out. So coming on to our factor, the first prime way of management is always giving optimal spectacle correction. And we are confirming it by doing a duochrome test. The next would be, always we prefer to give vision therapy. If the vision therapy is not working, then we manage the patients by prescribing prisms. If the fourier component becomes manifest, then the amount of deviation is calculated, and then we refer them to the strabismologist, and then they plan a surgical management. But we are not going into the manifest component. We are going to only stick on to the latent component. Therefore, vision therapy, this is our area. The role of an optometrist is more in giving a fabulous, treatment for the patients who come up with the convergence insufficiency. So the first treatment would be prism training. As I told you, you can give a base out training. It can be either in office. If it is in office, by using synaptophore, we can give them using a similar targets. I'm sure we have the slides in the Synapta 4. Though they say the instrument is obsolete, according to me, I feel it's a fabulous instrument, Synapta 4, because it is both therapeutic and also diagnostic. So therefore, Synapta 4, even today, if somebody says, I'm going to put it in the museum, I'll say, please, no, give that Synapta 4 to me. I can do wonders with my subjects. So please understand, when you're going to give, the convergence component, when we are going to improve, which is the second grade of binocular vision, the 3 grades of binocular vision. The third grade is stereopsis, second grade is fusion, and the first grade is simultaneous macular perception. When you're going to improve on this fusional component, automatically the stereopsis will improve, and that's going to help the subjects to play around, to move around. There are, so many surgeons I have basically given a treatment from a personal experience. Therefore, managing such subjects with convergence insufficiency, it's going to definitely pay us. It's very, very rewarding. So this is from my personal experience. So base out training using Synapta 4 and simple CAD card. I remember in the university where I worked, a plastic surgeon used to call me. She used to pull, she used to say, Jaya, you have to give me some kind of treatment. I will cooperate, I will do something. And all, you won't believe, people, when I say versions, it is binocular, accommodation is uniocular. So even a pseudo fake will have versions component. You won't believe, my HOD, who was a retired person, an ophthalmologist, who used to have this CAD card. It was kind of it was a, literally they used to keep it as a goddess frame on their desktop, and they used to call, Jaya, it's doing wonders for me. So please understand, we are having the real, I would say, the coals in our hand. The coal, the longer age of coal becomes a diamond. Like that, the simple stuff would make a lot of changes. And it's, their lifestyle, it brings a very big change. So as a vision therapist, you can just make wonders. A simple CAD card will help, and the Brock string. I'm sure all of you would have seen how a CAD card looks. My next slides, you can see the pictures moving around. The Brock string is there. Brock string, we can make the Brock string. In Amazon, you get it also. And it's just a string with 3 colored beads, and you just you train them to see physiological diplopia. Physiological diplopia, I'm sure all of you know how to appreciate physiological diplopia while seeing the the front target and the behind target will start appearing double, and you just start giving them the training to appreciate physiological diplopia, and thereby give this CAD card exercises. It's going to do wonders and wonders and wonders. And then there's something called tranaglyphs. This is, of course, nowadays lots of movies are also being played. Avatar, be it Avatar or name the mega movies, it's all, they wear red green glasses to see. Only if you have binocular vision, that is the second grade fusion, you can see, you can appreciate the depth perception, that is stereopsis. So I'm sure you value how much of wonders we are going to give around the people who are coming up with simple asthenopia. We may think it's simple. No, when you give a good treatment, that is a management from our side, they'll be very thankful to us, and the subjects, those patients would be our, in fact, a few of my patients, I would say, they become a diehard fan of yours also, in thanking you so much. And they spot wherever you are, they'll keep updating, ma'am, I'm good, I'm this, I'm that. Okay, so yes, when I say relieving prisms, it's very easy. You can give a ground and prisms on the spectacles. Ground and prisms up till 5 prism diopter in each eye, up to 10 prisms you can ground in. You can grind the prisms onto the glasses. So the relieving prisms would be base and prism. So moving on to convergence excess. So it's simple. It is just opposite of convergence insufficiency. You will get to see not exocomponent, esophoria. So the esophoria would be more for near compared to distance. As I told you, the simple tests, what we are going to do is Maddox rod test. First would be cover uncover test and alternate cover test, and then Maddox rod test, and then heterophoria method, you calculate AC ratio. These are the things, tools which we should we should follow in identifying the Convergence disorders. And then you calculate, you find out AC ratio would be increased, which means it would be greater than 6:1. So probably it should be around 7:1 or 8:1 or 10:1. And then management protocol here would be again glasses first, then you try vision therapy. Finally, you give prism correction. So when I say optimal correction, again, duochrome, the golden thumb rule is duochrome. So the duochrome has to be balanced. Plus lenses, as I told you before, two bases facing each other will be plus lenses. All right. So that gives a basin effect, which is an exercising prism here. It is just opposite, as I told you. For EZO, when you give a base in, it is an exercising prism, and relieving prism would be base out. So minimal add for few patients, few subjects we'll have to give because the ACA ratio will be too high. To compensate that, we give a executive bifocal for near work, and depends upon the symptoms also. So the vision therapy, yes, again, Brock string does wonders. Here we give a base in training. It is an exercising prism, is base in. Relieving prism will be base out. Synoptophore again does wonders here. Brock string, tranaglyphs. And what as a relieving prisms, we give a base out prism. Divergence insufficiency, this is the catch. So how are you going to differentiate divergence insufficiency? When you say divergence insufficiency, the eye is unable to diverge more. What about convergence excess? Even in convergence excess, the eye is more inside. How do you differentiate convergence excess and divergence insufficiency? Both would appear similar. The only measurement which will help us to differentiate convergence excess and divergence insufficiency would be esophoria for distance is greater than the esophoria for near. Sometimes it can also be ortho for near and ESO for distance. AC ratio, when I say insufficiency, that would be an easy way to remember. If it is insufficient, AC ratio is reduced. Whereas in excess, ACA ratio will be high. Therefore, in convergence excess, you will see the ACA ratio high. So this is how we differentiate between divergence insufficiency and convergence excess. So what would be the management protocol? Again, glasses by default, optimal correction is very, very important because simple plus lenses itself can help. Here, you should understand again, plus lenses gives a base in prismatic effect. Therefore, it does wonders by giving an optimal spectacle correction. Therefore, refraction is very, 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 very important for the management protocol. We also have to have a watch on lateral rectus paresis. So when I say lateral rectus is for what? Again, it's a brush up again. When I say binocular vision, we have to be really very good in all the extraocular muscle movement, nerve supply, and all the primary action, secondary action, and tertiary action. Lateral rectus is the action of lateral rectus. Anybody?
Abduction.
Yes, I didn't get you.
Abduction.
Abduction.
Is this adduction or abduction?
Lateral rectus is adduction.
Are you sure?
Yeah.
Sure.
If you
How
have
many, sir? Yes, Manish, is it? Manish, yes.
yeah.
So, yes, extraocular muscles, vertical muscles, oblique muscles. So how many recti? 4 recti and 2 obliques, right? So synrad, superiors are intortus, rectis are adductus, except which one?
Come again.
So
All the rectis are intortus, synrad, SINRAD. Please remember this Small formula. Superiors are all intorters. Rectis are adductors. Except which recti?
Lateral rectus.
Fabulous. So lateral rectus is not an adductor, it is an abductor. Right? So if there is a paresis of lateral rectus, then the eye will not be able to abduct. Instead, the eye will adduct. That is why it is divergence insufficiency. Okay? Yes. And except superior oblique, the other superior is only superior rectus. Superior oblique is for depression and not elevation. All right. So I'm only going to speak about recti here, except lateral rectus. The other recti are all adductors, superior rectus, inferior rectus, medial rectus. Then what else we have? Out of how many recti we have? 4. So 3 are all adductors except lateral rectus. So therefore, we have to see for the paresis of lateral rectus. If there is a paresis of lateral rectus, then the management protocol will change. As I told you, I'm not touching strabismic component. It is only non-strabismic component. And then we give a relieving prisms. Base out prisms are the relieving prisms. Coming on to vision therapy, what we do, again, a base out therapy, exercising prisms in office, synaptophore, cat card exercises, drop string, and tranaglyphs. So divergence excess and convergence insufficiency would mimic the same. Here again, what confirms divergence excess? Exophoria for distance is greater than exophoria for near. So probably it can be orthophoria for near and exophoria for distance. But in convergence insufficiency, classically, exophoria is more for near than for the distance. And when I say excess, in divergence, any excess, AC ratio will be high. Any insufficiency, AC ratio will be low. Therefore, in convergence insufficiency, AC ratio definitely would be lesser. So these two parameters are just, our golden rule. You have to just record these two and you can very beautifully, confidently, you can say divergence excess or convergence insufficiency. So what would be the management protocol? Again, spectacle correction, minus lenses. Minus lenses gives a base out. So when you put a minus, it's a concave, right? So, the concave lenses, it's thinner in the center and thicker in the periphery. Therefore, it gives 2 base out prisms. When they are placed together, it becomes a minus lens. So that gives a prism effect. Yes. So the vision therapy again here, base out prism therapy is given. You can give either through synaptophore, in office, right? And also you can try giving them base out prism therapy with the loose prisms also we can give them. You can ask them to look at the near target and you can ask them to read for a while. Usually we give synaptophore exercises for 15 minutes. So that would be more than enough, more than sufficient. Cat card exercises, Brock string, and tranaglyphs. Yes, so this is very, very interesting. Pseudo-convergence insufficiency. I'm sure until now, I have made things to an extent clear. Can I see the hands going up if you have really understood until this? Just to get a reassuring factor if my talk is okay with all of you. How many of you have really understood? Can you please raise your hands? Fantastic, Noah. Yes. Muan Gui, yeah? How do I say? Muan Gui. Fabulous, Naomi. Yes, Mr. Anil. Sorry for not prefixing Mr. and Miss. Yes, I think most of you, and the participants' numbers is also increasing, no? From 49 to 65. Fantastic. So yes, So this is giving me some confidence that I can move on to the next. Yes. So yes, pseudo. When I say pseudo, it is false. The falsification, it is misleading and misguiding a clinician to treat. Usually this is where there's a slip. You name it any surgery. I am, just for a lighter moment to have a break from the monotony talk what I was giving. It so happened that I've been browsing through. Nowadays you get reels and all these things. So there are celebrities who come up and saying, not the eye per se, I'm just talking about other things. They have some knee repair and they go for a first knee surgery, it becomes a failure, second knee surgery, failure, third also. Finally, they get to find out it's an autoimmune disorder. For an autoimmune disorder, definitely we will not recommend any kind of surgical protocol. Similarly, even to us, it would be a simple component, and there's no point in, asking them to undergo some surgical measure, and then they land up in having a suppression or diplopia. Finally, they coming to us. All such instances, probably even you must be seeing it in your clinical practice. So therefore, it will sound very simple, but as well, let's finish. I think it is in our hands. We may think it is just nothing, we'll neglect. Rod, it will hardly take this minutes, it will just take 1 minute or a few seconds for us to do it. Let's not ignore that component. And few of the time you will be hitting or banging our head and finding, hey, why should I do this? I don't have a Maddox finger. It's okay, no problem. Do with the Maddox rod. Have that. Now you know what you will have to do it. You just have to get this formula, feed in, find out, okay, this is ACA ratio. What am I going to do with this? The values will be there, but we won't know what are we going to do. So you got to collect a normative data, check with this and find out, okay, if this is normal, then yes, you don't have to panic at all. You can just tell them this is nothing to do with the eye disorder. It is something to do with something else. So please get your ENT checkup done. Or if not ENT, we should not give them panic attacks saying go to the neurologist directly. Tell them step by step, but as well, it's better. Even otherwise, it's better. We also refer them for neurological examination. But as an optometrist, we should have all these parameters recorded, or we should have it in our case sheet so that we give a reassuring note to the patients, and patients will definitely be thankful to us for lifetime. So yes, coming back to pseudo convergence insufficiency, it's very interesting. I have seen such things, when you are as a clinician, when we get to practice, when you find out and you give them a treatment, my goodness, it gives such a immense joy and a pleasure in sharing whatever you have or we have seen in our daily clinical practice, and that helps us to become a good teachers also in future, and also a clinical researcher. It's very interesting, when you have all these different parameters, you won't know what to do. When you do a lot of analysis and then you publish, that becomes a paper. So clinics is a main core ingredient. I'm glad to see so many clinicians pitching inside for today's talk. So clinics, please, for God's sake, let's not even keep it at bay. We have to practice clinics. At least one patient in a day we get to see and make some analysis. That helps us to become a good teacher or a good researcher. Basically, let's give a good service to our patients. So we can do wonders with whatever we have seen until now. So let's see what is pseudo. So when I say pseudo, it mimics like convergence insufficiency. Of course, it looks exophoria for near would be greater than the distance, but the ACA ratio would be normal. When you say convergence insufficiency, ACA ratio would be reduced. All right. In divergence excess, it will be more. So here, the ACA ratio is normal. Yes. So what is the culprit? Accommodative facility, we have to check. How do we check accommodative facility? If someone can answer, that would be great. How do we check accommodative facility?
Using +2 flippers.
With accommodative flipper, ma.
Extraordinary. Excellent. Excellent. So accommodative flippers, you find out the number of flips per minute, and you have a normative data, compare it, you find out the accommodative facility is reduced. So it looks like convergence insufficiency. Of course, NPC also will be receded, and your exophoria for near will be greater than the distance, but the accommodative facility is abnormal. Whereas in convergence insufficiency, accommodative facility will be normal. So you will be very confident this is a pseudo convergence insufficiency. So the treatment protocol would be prescribe them accommodative flipper exercises. The management first as prime role would be, please look for, even if it is minimal refractive error, diachromis balance, give them even plus 0.25 diachromis balance prescribe. Vision therapy, yes, exercises to improve the accommodative component, accommodative flipper exercises. Flipper, which means it's a pair of plus lens and minus lens. Plus lens will relax the accommodation, minus lenses will stimulate accommodation. So the inertia of accommodation, that is some kind of a friction is there. That's why they come up with asthenopic symptom, just like convergence insufficiency. You give them this. Otherwise, very simple heart chart. You can give them, a small letters, the font size and bigger font size. Place it at say around 6 meter distance. If it is 20 feet, in feet it is 20, otherwise 6 meters and 40 centimeters. So look here at 40 centimeters, one line, look at distance, the other line, which gives the same flipper impact. There's also lens rock exercises you have with a flip of plus lenses, take it with the minus lenses, flip with the near target, we do it. All right. So base out the therapy is also given. Synaptophore, yes, you can give, because exophoria, NPC, that also will help, but primarily by giving only this flipper exercises, they'll say, I'm fine, I'm doing great. All right. So then synaptophore, cat card, drop string, tranaglyph. This is basically, you eliminate that particular culprit, which is like you're improving the accommodative facility. Still, if there is an NPC receded and whatever this exophoria component is there, by giving the cat card, you're not going to kill them. You're not going to make the condition worse. Instead, you're going to improve their convergence component. Thereby, the fusion is improving and the stereopsis is also going to improve. Yes. So let's pitch into accommodative disorders. So when I say accommodation, again, this 1 hour talk will not be, in fact, I was telling her 20 minutes is fine. 20 minutes is not sufficient for us, because each and every component itself is so very interesting. So when you say accommodative insufficiency, I'm going to just put it in 2 ways, accommodative insufficiency and in facility. We just saw how a facility is. When you say insufficient means it is not sufficient. All right. So basically, we identify the amplitude of accommodation. How do you find out the amplitude of accommodation? One test to find out amplitude.
Hello, ma'am.
Yes.
You can first find the NPC and then you change it to the optic power.
Not NPC. NPC, it is convergence. So for accommodative, amplitude of accommodation.
When you check the near point of accommodation and NPA, then you change it into dioptric power.
Excellent. So NPC is, as I told you, convergence is binocular. So there is no OD as OU in convergence. It is only distance and near, subjective and objective measure. But if it is accommodation, you check NPA, that is near point of accommodation, just simple push-up test. There are various types, various methodology to identify the amplitude of accommodation. One simple test would be a push-up test. What we do, give a near vision target. You will have to take it closer to the patient, and the sustained blur is a end point that from the patient eyes until the target would give us the distance, that is near point of accommodation. 100 divided by the component will give us a dioptric value. That is the amplitude of accommodation. So when you say amplitude of accommodation, It can differ sometimes, but mostly it would be same. So OD, OS, and binocularly, because of Convergence disorder also, that can bring down the amplitude of accommodation binocularly. Therefore, we assess the amplitude of accommodation for the individual eye and also for binocularly for both the eyes together. So when we find out the amplitude of accommodation itself is less, which means we have an age-matched value, all right? So we have to compare it with whatever the amplitude we have found out. So if the amplitude itself is less, then it is called accommodative insufficiency. All right. If the amplitude of accommodation is normal, all right, and then you go doing a flipper, find out the accommodative facility to see the amount of ability of the eyes to relax and stimulate. If there is, then it is called that inertia of accommodation. Then you say it is accommodative infacility. I can give you a simple example. Okay, you are probably today is Onam. It's a festive in Kerala. It's South Indian festival where usually in the festive seasons it's a holiday. All right, so you go stand in a public transport. You're waiting for the bus. You wait for the auto. You will see that quite a few. No, it's nothing. You don't get the buses at all. So it's so annoying, no? So you know it's a holiday. And we know very well the services would be less. So which means you cannot expect the frequency to be more. So it is when the amplitude of accommodation is completely lost or it is reduced, you cannot expect the accommodative facility to be normal. Usually you have a lot of the depot of buses. It's always there. It's always functioning. But due to some whatever the accident or whatever, the amount of frequency of buses would be less. So that way, in facility, the amplitude is sufficient, but the ability to relax and stimulate accommodation is not possible, is called accommodative infacility. This is the difference between insufficiency and infacility. So I'm just going to run through the classic way of identifying is by doing retinoscopy. So retinoscopy, you know, I'm sure all of us are optometrists here, and there should be some orthoptists also. Usually orthoptists, they are not trained to do refraction, but still they depend on the values what an optometrist give. So static retinoscopy, static and dynamic. When you say dynamic, it is active. You're keeping the accommodation in play. In static retinoscopy, we are trying to relax the accommodation completely. If it is not relaxed completely, we do a cycloplegic retinoscopy where we paralyze the ciliary muscle and identify the actual refractive error. That is cycloplegic. So static and dynamic. So dynamic is a one, after doing a static retinoscopy, you identify a refractive error and you put that onto the trial frame for the distance you have found out. We have to do something called dynamic retinoscopy. Again, dynamic retinoscopy, I can take one full class for 1 hour. There are various methods to do a dynamic retinoscopy. One easiest or the method what we can inculcate in our usual clinical protocol would be monocular estimation method, that is MEM. What we do, we give a near vision target after doing a static retinoscopy, put that onto the trial frame, remove off this working distance lens plus 1.5, give the target. Then we have to see, ask the patient to look at the near target. Usually you also have a card which can be stuck onto the retinoscope and we have to look for the movement. If the accommodation is just normal, which means at 40 centimeters, 2.5 diopters of accommodation, that subject has to exert. If you get a plano, which means the accommodative capacity is fine, you're giving a stimulus and the response is also fine. So you don't have to think about hitting your head and finding if there is lagging behind or leading of accommodation. But when you get a with movement, usually we'll get a with movement, we will have some amount of lag of accommodation, say around plus 0.5. You do have a normative data for each population. Usually the established data is Western population. Few of the studies, in fact, it was my first study, we had initiated in finding out the normative data in Indian population. Indian population is huge. I would say hospital-based Indian population. Similarly, one of you can pick up as a project. You can start identifying the parameters, normal values in your particular country in Africa. And you can find out the normative value, because from Western population and from us, ethnicity, there could be a lot of differences. You establish whatever we have, based on that, you say, you compare, and then you say if it is reduced or if it is more or if it is normal. So this dynamic retinoscopy, when we do, we find out this is normal, this is universal. At 40 centimeters, 2.5 diopters, 100 by 40, 2.5. You don't get a movement, which means it's normal. When you get a movement, it is lag of accommodation. With movement, it is lag. If it is against movement, it is called lead of accommodation. Lag of accommodation, which means instead of 2.5, if that subject is accommodating only 2 diopters, which means he or she is lagging plus 0.5 diopters of accommodation to see that particular stimulus at 40 centimeters. If we get against movement, then, for example, minus 0.5, which means they are over accommodating by 0.5 diopters at 40 centimeters. So what are we going to, with this data, what are we going to analyze? When there is a lagging of accommodation, which means there is no sufficient amount of the capability of accommodating. If there is a lead of accommodation, which means they have too much of accommodation. So this itself gives a very good, it's a nice way of identifying if the particular candidate has accommodative insufficiency or accommodative excess. So for sure, in insufficiency, you will have more of lag of accommodation, and in excess, you will have lead of accommodation. This is the difference between accommodative excess and accommodative insufficiency. All right. And there are few of the tests which is called negative relative accommodation, positive relative accommodation. Any clue how to do NRA and PRA? Anybody?
Yes.
Yes. Can you please explain?
NRA?
Yes.
As we are saying, the accommodation is, when checking there, you look for what stimulates accommodation and what actually relax accommodation. So for NRA actually relax accommodation. The name is negative relative accommodation, but actually it has to be done with plus lenses. So you have to start with 0.25 lenses, you add it on top of the prescription of the patient. The patient prescription should be there, and then you give a target to the patient of 40 centimeter, and then you increase adding that by 0.25, and then ask the patient to look and tell me where that target get blur. So once it get blur, then you actually note the dioptric power. But whenever you are adding, you add on top of the lenses. Then for positive relative accommodation, you do it with minus lenses. You start with 0.25 by 0.25 in sequence, and then whenever you are actually putting, you remove the lenses before adding on top. So here, for the negative relative accommodation, you know your powers. For the positive relative accommodation, you know your powers. And each one should range, the normal value should be plus or minus 250 diopter. The normal value should be around that. If it is less than that, then there is a problem. If it is more than that, it is still fine.
Awesome. Fantastic. Awesome. So yes, the normal values again, please, 2.5, I don't know from where you got this 2.5. There is established literature by Saladin and Sheedy. You have a value, you have so many, and Sheeman and Wick is a fantastic book. That's a reference what I have. It's a Western population. Why don't you take it as a project? Noah, you are from where? You are from which university?
I am from Shushant University, passed out this year.
All right. So, oh, you passed out this year. Superb.
Yes.
Awesome. Hats off to your teacher.
Thank
The teacher
you.
has trained you so beautifully. It's not only the book which has taught you, I'm sure you're seeing patients that has helped you to, be so super confident in explaining NRA and PRA. So this helped me to, go back, retrospect and tell you there is also negative fusional versions and positive fusional versions. There you have negative fusional versions. It is again the eye. The eye has to move inside. You give a base out. You find out blood break and recovery. If it is positive, the eye has to move out. So you give a base in. Again, you have a blur and a recovery there. There also you have the values. Morgan is the one who is established and he has found out for NFV, PFV. Similarly, for NRA, PRA, usually you have, it's okay, 2.5, maybe 40 centimeters you have calculated, but it can be around 2.25, it ranges, all right? So fabulous. So this would also be one part of this NRA checking would be in Borish Delayed, which comes under binocular refraction, that is balancing of accommodation when we are prescribed. That's why I told you we should be proud to do a refraction. We are also a refractionist. So a refractionist is one of the components of the broad spectrum of visual sciences. As an optometrist, we are also we have to be a very good refractionist. So with these values, you find out NRA and PRA. So the positive relative accommodation will be, which means we are using a negative lens. The ability to stimulate accommodation will be lesser in accommodative insufficiency. So therefore, accommodative insufficiency amplitude is less. Lack of accommodation will be there. Positive relative accommodation will be reduced. The management protocol, very simple. We have to give demand and supply. So if the supply is less than the demand, definitely we have to prescribe a bifocal based upon the demand of that particular candidate, not just looking at the Dondas table. 40 years, give 1.5. 50 years, give 2 daughters. 60 years, 3. No, not at all. 35 years, we can even get a youngster who's coming up with an accommodative insufficiency, probably undergoing a psychoneurotic drug that can also induce this condition. They can come up with this problem. Therefore, let's not blindly follow whatever the tables are there. We have to record NPA, calculate the amplitude of accommodation, then go about in giving the management protocol. Therefore, management, again, spectacle correction is very, very important. Full lens plus lenses is very, very important. The ad is prescribed. This is again very, very, very important ad. As I told you, don't blindly follow. Do not follow. Don't.
We all know you're not going to deliver. We got the hell.
Sorry, I think I was muted. Yes. So
Sorry.
yes, we have. No
Sorry,
problem. No
yeah,
problem.
I was trying to mute the guy who was below you.
Yeah, I got
lot
it.
of
I got it.
background noise. Sorry about it.
So yes, the other way of doing is offsetters formula. You can have it, and also the best way is calculate the amplitude of accommodation. Let's forget all the normative data. Just go by the subject. The subject's demand and supply. So demand would be the working distance. Profession is very, 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 very important. Ideally, there are so many, I do not know to call ourselves as presbyope or whatever, because I don't think most of us wear glasses. So it depends upon the accommodative component, how well your visual system you maintain, your lifestyle, your habit, your nutrition, so many components helps us. So your whatever the drug intake and all these things also would be an influential factors for reducing or having a very good amplitude of accommodation. So therefore, Profession is again very, very important. Sometimes we can manage beautifully without wearing, we can delay the wear of presbyopic correction based upon the professional needs. So professional needs, when I say as a teacher, what would be your kind of the tasks? As a musician, what kind of task you would need? As a tailor, what kind of a task you will need? As a watchmaker, what kind of a task you would need? So the demand depends upon the type of nature of the job. I cannot give a farmer just because he is 40 years or she is 45 years, give them a bifocal blindly and send them across. Not required. Depends upon what kind of professional needs they have. Therefore, the working distance is very, very important. At a clinical setup, we will just look into it and we will say, no, ideally we have to ask them when it is going to be a binocular vision clinic and orthoptics clinic. Definitely time is sufficient for us. We got to spend time with the patient, identifying what would be the nature of job. Surgeons, again, they may not necessarily do a surgery at 40 centimeters. They might even do at 70 centimeters. So accordingly, the ad is prescribed. Therefore, you calculate the amplitude of accommodation. That would be the supply. We cannot give the entire supply. When you just look into the car, our engine, it'll just pop. The petrol thing will pop up. Not when it is completely drained. When it is 3% or 30%, when you have it just honks like that, we got to put something in the reserve. So how much usually we have to keep it in reserve? According to British method, it is 1/3 of the supply should be keep it in reserve. According to American method, which is very easy, half in reserve. Say, for example, your amplitude of accommodation is 14 diopters. You put 7 diopters as a reserve. If your amplitude of accommodation is only 5 diopters, you keep 2.5 diopter as a reserve. The remaining would be our supply. You have to find out if the demand 40 centimeters is my working, which means 2.5 diopters. 70 centimeters, my demand is not more. So if my demand is greater than the supply, then you prescribe an ad. If my demand is lesser than my supply, you need not touch at all. If my demand is equal to the supply, you need not give any additional classes. So this is the prime rule. This would be your take home message. Please, if I can do this, I think that is what Tanuja is looking for. We have hit the target. So there are fresh graduates who can pass on this information. Please calculate demand and supply and then prescribe the required ad for that particular individual. That itself would be a great clinical pearl for today. Yes, accommodative in facility, as I told you, it's very, very simple. We have to do an accommodative flippers. If the number of cycle is lesser than whatever the normative value we have, again, flippers can be done uniocularly. Monocularly, you check for OD, OS, and also binocular. You just put a tissue or something, you cover the one eye. Don't press the eye. That also can induce and can give us a false way of examination. Examining each test itself is step 1, step 2, step 3. We got to be very professional in examining to get the actual value parameter of that person. And also depends upon, there can also be a diurnal variation in many things. When they're tired, if you check, that can also do things. So ensure that you keep the patient, like how they check BP, like that. Even all the parameters in a visual clinic also, we got to understand, empathize the need of the patient and go by examining, be very pleasing and very nice. And with the parameters, we should know how to play around, how to give an appropriate management. So it's very easy for us. Accommodative in facility, vision therapy, it's super easy. You can make heart chart by yourself. Otherwise, calendar is sufficient. It's a big, big letter, no? It's stuck on the wall, and a small newspaper, probably N6, N18, even N12. You look at one line for near, then for distance, ask him to see. Even otherwise, look at the green. No, we say 20, 20, 20. Every 20 seconds, look for distance at 20, feet for 20 seconds. So keep it as a peep like that. You can just ask them to train in office. At home also, they can do it. Yes, this will help us in managing effectively patients with accommodative in facility. spasm of accommodation. This is the most, what to say, almost most of the kids during this corona times would have landed up having this spasm. And I get to see, my goodness, the parents have, in India, I would say it's like technology is a boon as well as a curse. To feed, they have the mobile in their hand, they see the cartoon. When they're flying also, it's always the cartoon to, pacify the baby. But what happens? The near work can also, you're using the accommodation more and more and more. Therefore, the fatigueness, everything happens, more of accommodative excess can lead a spasm, complete spasm. And also that nowadays, most of them say depression. They get into psychoneurotic drugs can also induce spasm of accommodation. Therefore, we have to be very, very careful in identifying the spasm of accommodation. If we can release the spasm of accommodation, the other the iatrogenic factor, I would say, from a refractionist perspective or an optician perspective, even optometrists, for that reason, nowadays I hardly find the young buds, having a retinoscope. Retinoscope is like a stethoscope for a physician. An optometrist should have the pride in carrying a retinoscope. Do a retinoscopy. Just doing an autorefractor, definitely you overcorrect, you give them minus, you put them into a spasm. Later on, breaking the spasm, giving them appropriate management, it's a real, very critical thing. You ask them to remove the glasses, they'll feel so handicapped. So therefore, accommodative spasm again, but if they really have a spasm, we have to treat. So how are we going to check here? Again, the amplitude will be, sometimes even the supply will be over, too much also, but usually it is demand is equal to supply. MEM, you will have lead of accommodation. It's again my doctorate, my thesis was on cerebral palsy. In cerebral palsy, again, we found there are kids who have spasm of accommodation because of the spastic thing, they have how to break the spasm. It's really very challenging task to break the spasm. Again, here, negative relative accommodation will be reduced and positive relative accommodation will be more. Am I right? Negative relative accommodation will be more here. Okay, and the lead of accommodation also will be more. Yes, so optimal spectacle correction is given based upon the duochrome. Say a big no to the minus. When you're going to treat spasm, we are going to be very harsh. You have to please make them understand. My own personal experience, I have seen the people who are given minus lenses who have accommodative spasm, the pseudomyopes, they tend to wear a bifocal at the earlier age. So they come up, it's like eating up of prisms. They take more of bifocal. It so happened she was a very high profile person. When I got to see a dynamic retinoscopy, when I did, there was a lead of accommodation. Static retinoscopy, it was plano, and lead of accommodation. When I had to just tell that person, you don't have to wear glasses. She was planning to take a contact lenses, and she was a pre-presbyope. This experience I always share with my students also. You won't believe, even today she is very thankful to me. This I would have done some 15 years ago. The spasm can cause an individual to push themselves to wear bifocals at an earlier age. Therefore, there are patients who used to curse. I'll say, you're going to whip me if I'm going to abduct this minus lenses from your, whatever, your case. So they would definitely feel like thrashing us also, but we got to tell them we are doing good for you. So even a minus 0.25, if you ask them, please don't wear this minus 0.25, they'll feel very happy initially, but then it is like terrific and terrible for them to cooperate with us. So therefore, treating a spasm is quite challenging, but it gives such a very good, satisfaction at later on when you see the patients, the longevity, what I mean is longevity of management, which means they are not going to wear a presbyopic correction very early, and they'll be definitely very, very thankful to us for ages. So yes, so again, the therapy, we have to give them flipper exercises because both relaxing, we are trying to balance stimulation and the relaxing component, hard shot, accommodative rock exercises to be given. Yes, so we are going to finish. So Indian time, it's going to be 11 o'clock. Unbelievable. So yes, the take-home messages, it's a kind of a cycle. Ensure that we are identifying Convergence component and accommodative component. Based upon that, go by giving the vision therapy exercises, which is our the real pearls are there in our hands. How are you going to mend the pearls and how are you going to garland it to a patient? It depends upon a proper clinician who can identify, who can diagnose the condition by using the parameters, analyzing the parameters, giving a statement, this is the condition and this is going to be your management protocol. So yes, these are the references. All these books are fantastic book. So my most favorite would be Michelle Sheeman and Wick. My full notes is again on the topic was on normative data in orthoptic evaluation I had done in hospital-based Indian population. Most of it, I literally kind of enjoyed learning every single page of Mission and Sheeman and Wick. So thanks to such brilliant people who have done an extensive work in binocular vision. And we have to, it will be nice, my recommendation, please go through that book. You should see every, after the, every topic, there will be a case discussion. That would be really very interesting for each one of us. That will help us to also write case series by ourselves. And Primary Care Optometry is my all-time favorite book. I still remember people when they get to see me in US and RO conference, they'll run and say, Jayarajni, you used to tell us in the first year, this is it has to be treated as a religious book. It should be either a Gita or a Bible or a Quran. Similarly, every optometrist should own a Primary Care Optometry. Theodore Grosvenor, he is no more, but still thankfully he's done a great, we have real pearls. The gems are hidden in that Primary Care Optometry book. Retinoscopy is again a very nice book. Duke Elders, I'm sure all of you will know it. And Pediatric Kenneth Wright is again another wonderful book. So thank you all. Thank you. So thank you, Tanuja. I'm sure I have justified to an extent. Any questions? You're open to discuss. Thank you.
Yes, ma'am.
Any questions, please?
Yes, ma'am. Hello.
Yes. Who's that?
Noah. Yes, ma'am. If you have a patient who is having like convergence problem, and then you have the same patient having an accommodation problem.
Be specific. Convergence what? Insufficiency or in excess?
Let's say you have a patient that has a convergence excess and accommodation insufficiency, for example.
Giving an example, I want you to think logically. When there is a convergence insufficiency, as I told you very clearly, keep this in mind. Convergence and accommodation are syncretic, they are friends. When you have anything insufficient in convergence, it will have an impact on the accommodation. Therefore, it should be insufficiency and accommodative insufficiency. All right?
Yeah.
This excess, convergence excess, you can have accommodative excess.
Okay.
So I get the feel of what you are planning to ask.
So let's say you have an accommodative insufficiency and convergence insufficiency together in one patient, for example. So which treatment, which therapy will you pay attention to, the accommodation more or the convergence more?
like a chicken egg story. So as I told you very clearly, for me as an optometrist, as a clinician, I would look from the symptoms of the patient. So the patient symptoms, my first prime choice of treatment, the protocol itself we have given, give them optimal spectacle correction. Therefore, when you say the accommodation, if it is disturbed, definitely there is going to be an impact on the refractive error also. Therefore, the first primary goal would be give them a proper refraction, that is the spectacles. The spectacle itself has an inbuilt prism where it will take care of the Convergence component. So the primary goal for us to give an appropriate optimal spectacle correction first. All right. So when you say insufficiency, poor person, the amplitude is lost. What is the point in killing that particular candidate and giving, hey, you have this, so you definitely come to my office and do sign after 4? No, first would be give them appropriate glasses. So demand and supply, give them a proper bifocal. That itself will rectify 80% of their whatever they have come for. You empathize them, you have given it. After that, we are going to reevaluate and see how the Convergence component is. If the Convergence is insufficient, give them a CAT card, give them home exercises. We need not just make them to come up and down, do only sign after 4, you bring in the magic, not required. Home therapy would help. And nowadays, there is a lot of established, nice gadgets are there. But usually I'll prefer to give only the simplest thing which can help them. It does wonders. So yes, so this would be the management protocol. Again, the crucial way of identifying accommodative excess and Convergence excess again. It's very, very interesting to discuss on what is the reason for Convergence insufficiency. All right. So it's nice that you asked that question. You have types of Convergence: fusional Convergence, accommodative Convergence, tonic Convergence, proximal Convergence. All right. So the fusional Convergence, you can identify using NFV and PFV, you have the value. You also have a sign after 4, you have identified. Why they have this when they use an excess of accommodation? Yes, there is a possibility of secondary to accommodative excess. They can have a Convergence insufficiency. So your question is also fabulous. So you got to look if there is an accommodative component is the reason. Using of accommodation because of the spasm, that is giving the headache, and this has given an Convergence insufficiency. Then the first modality of treatment would be to relax that particular component, give them accommodative flipper exercises, give real good training, give them heart shot, give them rock exercises, ensure that unnecessarily if they're wearing a minus lenses, take away that. Then you see slowly the Convergence insufficiency component also vanishes off. So primary goal, proper refraction. No just auto refractor. I'm sure in the camp and all you cannot, still they do carry, but yes, doing retinoscopy, static, dynamic will give us a real good clue. And also this NPC, blur, break and recovery, you can identify which component of Convergence, if it is accommodative Convergence or fusional Convergence, then you can strengthen up the fusional Convergence by giving this whatever triglyphs and broad string CAT card exercises. Hope I've answered your question.
Yes, ma'am. I have another question. Hello.
Yes, please. Interesting.
Yes. For excess convergence, is push-up an ideal therapy for it?
For excess, yes. Again,
for excess, because the convergence is already excess, and sometimes I hear push-up, so I'm kind of confused sometimes. Is it too ideal?
see, ACA ratio is high in Convergence excess. Therefore, it is better we give them a relaxing therapy. All right. The relaxing therapy would be more of abduction component you will have to concentrate. If you are having a sign up to 4, you will be using a base out therapy for working on to the convergence component. Now you have to abduct the eye, so you go on abduction and you can give a basin therapy. That is basin therapy. Again, your Brock string exercises. Brock string is fantastic. You have the 3 beads. You see a V, X, and again a inverted V. If you can train that, which means you are trying to bring in, it's again the physiological diplopia component, what we are trying to do, you can do that. And also, what else can you do in a convergence excess? When the convergence is excess, which means again the plus lenses. If you have a minimal hyperopic correction, give them plus lenses. That would relax whatever, it is because of the accommodative component. Okay, yeah.
Thank you, ma'am.
Ma'am,
Very interesting.
I have a
When you
question.
see
What's
patients-
your take on like if you the way which you are explaining there's American way and the British way, what's your experience on which method you prefer or which one you feel it's more appropriate, the British way of relieving the 1/3 or
You
the
are-
American way?
Yeah, so this is just a lighter note. We all of us were ruled by Britishers, inclusive of Americans. Americans also have an Independence Day celebration. So Americans are very super cool. It's half. 1/3, if you calculate, it would be even more stricter. So I prefer a British method.
Lower
Even in
end.
English, we prefer a British method, no, compared to American style of speaking. We go by British method. British method is the one late Dr. Vaidilingam, he is a principal. I'm sure Dr. Tanuja also knows him. I do not know if you were there, Tanuja, during Vaidilingam search period?
Yeah, I was definitely there. He used to take us low vision and geriatric optometry subjects.
In ortho-optics and binocular vision for us. And binocular vision 1, Dr. Ravi Shankar, probably he was blessing, his soul was blessing, it was pouring rain. And he always used to insist on all these things. We were trained to do a British method. So that's the take, my take, even until today.
Okay. So it means a more ad.
If you calculate, you just see 1/3. Is 1/3 more or half more?
Sorry, lesser
You're
ad.
keeping it in reserve. Yes, lesser. I go by lesser.
Okay.
Add, you give less. But for distance, I am liberal in giving maximum plus. Diagram is there. But for near, I go by the demand of the patient. Basically the professional needs, no?
One more. I'm like, it's out of context. I want to ask you, like, I mean, nowadays, since there is a lot of people have been using a lot of computers and mobile, but I'm seeing even the higher ads, even for higher like age people, like maybe a 60s, we're not able to get the +3, which we used to get it in earlier days. I mean, this is my personal take. We are settling with +2.5. We're not able to go for beyond 3. They are not able to manage with +3, and then we try to reduce.
Not able to manage. You mean to say not able to manage, or are we giving lesser ads?
So they're not able to manage with +3, and then we're reducing their ad to lower ad.
That's good. That's great. Thanks to the surgeons, no, because they are calculating. They are aiming for minimal ad, for near also. They want to exclude. That's why they give for distance. They aim giving a minus. You got to look at the distance if they are pseudofix. And also, thankfully,
even the person is wearing a plano number. And the person been wearing +3 and then say, no, I'm not very happy. And now giving by +2.5, they become more happier. So this is my personal take, is that people are now adapting with the lower ad. Is it a norm which is you also experiencing, or
that's a great sign, I would say, because it so happened that I was given an opportunity to give my talk in Bascom Palmer Eye Institute, where the scientists are all working on how to manage effectively a presbyopes by not giving classes. So very boldly I said yoga would help. And I personally am practicing yoga, and the lifestyle, the habits, what we do, probably nowadays people are more health conscious besides using the gadgets and whatever. It's become an oxygen nowadays. It's a joke that, give an identification. The mother says mobile in the left hand is the identification mark. So it's become like Kavasa Kundalam. Most of these Indians would know Karna was born with Kavasam and Kundalam, like that. Nowadays, the kids are all with the iPhones and the phones. Yes, jokes apart. So what I feel, the habits, the health habits, the bag itself has around plus 0.5 diopters, that is the posterior capsule. So probably that helps. And there are, personally, I have seen 80-year-old, senior citizens not undergoing cataract surgery, still with minimal ad. Also, they're very happy because their lifestyle, their habits, especially Keralites, they eat a lot of coconuts. And thankfully, we had wonderful teacher in biochemistry, Dr. Ramakrishnan sir. He used to tell glutathione has an impact on this, which is the insoluble proteins and soluble proteins. When the soluble proteins gets converted into insoluble, you have a cataract, and then secondary cataract also after pseudophakic. That's the way they undergo a yak caps. So this, whatever the sundal, what you have proteins, the food habits, what an Indians usually, what we have South Indians, idli has a lot of urd dal, the urd dal has a lot of proteins. Probably in Africa, you have rich resources. The lifestyle, the habit, what you consume, there's a lot of biochemical reactions which is happening. It is just not only go by the Dondas table. That's what I told you. So it's a nice sign that they are having a lesser ad. That's fantastic. Probably their lifestyle, their habits is also helping them. This is what, and as you say, yes, 2.5, and moreover, we stuck into it. There are days you won't believe, even 50 they used to give plus 3, mandatory, just like that, give 3. Why? What is their profession? It is not required. It is not required. So things change. Probably our educational standards are also improving. So that can also be one of the components. And otherwise, from the patient perspective, I would say the nutrition plays a vital role, in their habits. Probably they are too very healthy and they're very active. That could be the reason.
Yes. Yeah, I think so. Like the food habit does.
Gujaratis also, the various. I'm taking my ethnicity as an example. Probably Noah can give some examples about his traditional food. Almost, I think they also take a flavor of Kerala food, if I'm right. So more of coconut is used. So coconut has lysine, if I'm right. It has that wonderful component, which delays even graying of hair. I hardly find people having too much of gray hair here. So like that helps. And the posterior capsule itself has some amount of accommodation. So one, Dr. Vandana Rajaraman, she is my immediate senior from Allied School, she had done on pseudo accommodation component, where it is even besides cataract surgery, pseudophakics, they don't. This is a classic reference what I can give you. I do not know if she's published it. It was a fantastic study where she found people after post-cataract surgery, pseudophakics, they were not prescribed with +3. Why? So the reason is plus 0.75 diopters to around 1 diopter. The posterior capsule also plays a role in accommodation. So this is what was the the result or the conclusion of the project was. Any other questions? So probably one plate of biryani from there will be nice. Tanuja, it's going to be 11:30 p.m. here.
Don't even remind me of food now. I'm hungry. I didn't even have my lunch. I had to dash to home and come back to the clinic because there was no power at home. So this we are the host, isn't it? Yeah. And to add to what you were saying, do you think stress, African, I feel they are irrespective of the financial background, they are free in their mind. They do have stress, but the stress the amount of stress we add to ourselves on the Asian side is phenomenal because of culture, education, and overuse and abuse of the eyes. When compared to African side, I feel that on the Asian side, it's too much of abuse when it comes to use of the eyes as well as the mind. So that could also be the factor, plus the meal. They eat a lot of maize, and that could also give some kind of strength. We don't know. We have not done any kind of maize
Yes,
meal.
nutrition.
Yeah, they are very
Nutrition.
that way they are very healthy and strong than us on the Asian side.
And how as you said, utility of the visual system also matters. So how much, if you're voracious reader, definitely they're going to have some kind of a disturbance.
Yeah.
Either they'll end up becoming a myope or whatever. Yes, and be happy.
Yeah,
I shouldn't be.
There's
Then it becomes a Om Shanti class.
Yeah, you don't even have to go for those classes.
No, because no. As you said, the depression is again if you look into the Americans. So for 35 wear glasses. When I was, I don't want to reveal my age, but still it so happened when I was less than 35, when I was 34. Dr. Jim Sheedy, his publications are there. I did have an opportunity to go as a visiting scholar in Pacific University. So he was like, you're 34? Wear glasses. I was doing my PhD. So it was something to do with I did have vertigo, something to do with your neck issue. So that's why that helped me to work on cerebral palsy kids to look at their accommodative component. So the stress is the most important component. Even our neck, even the physiotherapists, we can work small projects. We can just look into it. Depression. Any antipsychotic drugs can also induce, some kind of disturbances in the accommodation. So therefore, Americans, they are very super cool. By 35, they wear a bifocals. So that is what, so the habits, of course, peace helps in many ways. Anyway, yeah. So at least peace pulava anupunga. Tanuja.
Okay, you should come down and have our combination of food.
I'm eagerly waiting to pitch into your place. So probably in near future, God bless, God willing, should be able to.
The AFCO region, when they have some international conference, we have Professor Naomi here. She has brought her whole batch of Ugandan, I don't know whether it's students or practicing optometrists. We had large number here attending the presentation. She should be collaborated so that we can bring you.
Still, the number is close to 40. That's brilliant. I'm surprised to see the number still.
Yeah,
that's really nice. That's fantastic.
It was 67. It dropped to, some of them have
65. It went to 65. 69, I guess. 69.
69.
So you're a brilliant leader. Great coach.
I think you are a great orator and a presenter, and that too.
Thank you so much.
Got the crowd pulling. Thank you for an excellent
thank you.
presentation. Mr. Optom Maje, are you there? Would you like to add on anything? Optom Tato, Srujan, Manish. Manish has been chatting with you.
Yeah. Manish and Noah. Nice.
We had
wish I get to see all of you physically.
Dinio was also there. She's very much interested into academic kind of webinars and lectures and CPD. She's one of the.
Tanuja, I'm most welcome to do some kind of collaborative work. We can do some research in future. I would be most, happy, or I'm most willing to guide them, mentor them in future. Even short projects, small projects, I can guide them through. So now I have some brain where I can push into it. So yes, even optometrists, we can do some collaborative work. Yes. So
definitely. Let us finish our genetic third batch of students. Then we'll start off. I think we'll end this year and then we can make a plan for
that. Sure.
Would you like?
Thank
to-
you. Thank you so much.
Yeah, sure.
Shri Matre Namaha. Thank you. Thank you. Bye. See you all.
Yeah.
Bye bye.
Bye.
Thank
Good
you.
night.
Good night. See you.
We would be sharing this presentation and also sharing the link on the YouTube, if that's okay with you.
Thank you.
Thank you. I'll take a leave.
Yes, good night.
Stan,
Yeah.
love you.
Thank
Bye. Thank you.
Yeah,
Thank
sure.
you. Good night. Thank you.